Hi, we're at iwNHL 2018, and we just finished a session on T-cell lymphoma. We talked a lot about the biology of T-cell lymphoma and some new and interesting data. One of the things we talked about is the role of checkpoint inhibitors in T-cell lymphoma, which is still, I think, an open question. There was some data published recently about acceleration of disease in HTLV1 patients. And Jürgen, you had some very interesting molecular data that you presented to us about the role of PD-1 as a tumor suppressor gene. Do you want to go into that in a little bit of detail?
Yeah, sure. I mean, over the last years, it became clear that many types of T-cell lymphomas are really characterized by activating mutations in TCR pathways. So in those pathways that a normal T-cell utilizes after sensing the antigen to drive the adaptive immune response. And we have generated mouse models that mimic the human disease and performed genetic screens in these models, completely unbiased genetic screens, to identify the tumor suppressor genes that can counteract these oncogenic signals in T cells. And to our big surprise, the number one hit that we identified was the PD-1 receptor. And this caught, of course, our attention and intrigued us a lot because these PD-1 inhibitors are in so many clinical trials these days. But when the tumor cell is the T cell itself, right, then the PD-1 inhibitor would probably not only release the signals from the microenvironment, but can also accelerate the proliferation of this T cell tumor cell. And we have correlated this then with human data sets and found that in large cohorts of human T-cell lymphoma patients, overall about 1/4 of the human T-cell lymphoma patients have lost the PD-1 genomic locus, at least one allele. So this indicates that in T-cell lymphomas, this PD-1 is an important brake that can stop malignant proliferation.
What's interesting is that in addition to the HTLV1 diseases, in our clinical trial with CTCL, we saw a number of patients also who had disease acceleration on the checkpoint inhibitors. And I'm wondering if this could potentially be an explanation.
I think this could be an explanation that these tumor cells still have PD-1 and depend on this brake to keep it under control, and if you treat those with checkpoint inhibitors, that you can accelerate the disease. And I think it's now, I mean, you also showed this impressive data that a lot of these patients also benefited from the checkpoint inhibition. And I think it's now a key question in the field to really define biomarkers that determine whether a patient would benefit from the disease, whether the checkpoint inhibition doesn't do anything or would even harm and accelerate the disease. I think this is very important for the future.
Clearly, I don't think we want to say that patients shouldn't get checkpoint inhibitors with T-cell lymphoma, but do you know if there's any way that I today can screen a patient and determine whether that's a patient that might accelerate?
I think today we don't know what the factors are. We have limited knowledge now from the mouse models. And I think it will be very important to do comprehensive genetic profiling of the patients and correlate this with mechanistic data from preclinical models like the mouse models or cell line models and bring these two sides of the coin really together to get information for the benefit of the patient.
One of the other things we talked about today are the cell of origin. So the innate immune effector type T-cell lymphomas versus the more adaptive, more common subtypes such as PTCL and angioimmunoblastic. Do you think there's any difference between those two subtypes and potentially their response to checkpoint inhibitors or some of this inhibition that you're talking about?
Yeah, we can, from our data, only say that in these adaptive T-cell lymphomas, these are the only ones that we have studied, that there we find a clear negative regulatory role for the PD-1. For the innate, you know, as I understand your clinical data, these patients probably benefit from the therapy. What the role of the PD-1 receptor in these innate cells plays is, to my knowledge, still not very well explored.
We also talked a lot today about some of the other mutations in T-cell lymphoma, and Laurence Delaval gave us a lot of data about JAK-STAT pathway mutations and SED2 and other epigenetic mutations. So I think this is a very complex landscape with respect to mutations and potential targets for therapy.
Yeah.
It's difficult to figure out how we fit the checkpoint inhibitors in with some of the other things like epigenetic modulators, which we know work in this setting.
Yeah, absolutely. And I think that will also be a question, a key question, whether these mutations in other pathways, how they dictate responses to checkpoint inhibitors in T-cell lymphomas.
I think what's been interesting about our session today is gaining, of course, additional information on these pathways, but also I think it leaves open the question of what is the next frontier in T-cell lymphoma, where are we going, and how are we rationally combining these strategies. And I think certainly we both agree that molecular analysis of the tumor cell is the most important thing. And clinical trials prospectively should start looking at the tumor and the tumor microenvironment to try to figure out what's the relevant pathway and what drugs target that pathway most effectively.
Yeah, absolutely, yeah.
Thank you very much.
Yeah, thank you.
It's been a pleasure, and we've had a great session today.
Yeah, I also enjoyed the session, and I learned a lot from your clinical data. It's really intriguing, and I think there's so much to do in the future to really identify the patients that benefit from these therapies. Thanks a lot.
Thank you.